Good morning, ladies and gentlemen, dear colleagues, welcome, and thank you for joining our symposium on innovative radiopharmaceuticals for diagnosis of prostate cancer. As you know, Curium is a global leader in radiopharmaceuticals. We develop, we produce, we distribute SPECT, PET, and therapeutic radiopharmaceuticals for approximately 15 million patients annually globally. We will serve even more patients because our great UK Curium team opened 2 new production sites in Great Britain, in Newcastle and Oxford. Today with us, 2 distinguished speakers. So Dimitrios Moskonas. Dimitrios is urological surgeon, and his focus is on prostate bladder cancer and minimally invasive robotic surgery. Also with us today, Professor Vineet Prakash. Vineet is a nuclear medicine physician and also radiologist. Both of them are coming from Royal Surrey Foundation Hospital. I would like to mention also that Dr. Prakash, Professor Prakash, has experience with many radiopharmaceuticals for diagnosis of prostate cancer, from choline up to fluoride label DCF-PYL and fluoride label 1007. Both of them work together and they join MDT meetings in their hospital. And today our idea was to show you how the real MDT meetings look like. So we will go through 3 cases. The first one will be about initial staging of high-risk prostate cancer patients, and 2 more about biochemical recurrence. Thank you very much for being with us today. So the floor is yours.
Thank you very much, Marina. Thank you, Curium. Thank you, audience, for being that early in the morning and joining us in this nice, we hope, session. So on Tuesday mornings with Professor Prakash, we are in the MDT in Royal Surrey in Guildford, and that's what we'll try and replicate today with 3 cases we hope interesting for you. So the first case is a 73-year-old patient that presented through the 2-week rule pathway from his GP referred because of the PSA being 7.9 at an annual health check. His past medical history includes erectile dysfunction, hypertension, atopic dermatitis, and hiatus hernia. Current medications you can see on the board. And then in terms of the history that we have taken from the patient, he's describing some frequency and urgency, no hematuria, no infections. The symptoms score, which is the IPSS score, 18 out of 35, which signifies significant level of bother from the symptoms. And then when we asked why the symptoms are there, he says that he drinks 2 large mugs of coffee each morning.
May I kindly ask, why is this information important for you?
It's quite easy to separate British people from the rest of Europe because the European one would say coffee rather than tea.
Okay.
But to be serious, that it is important to understand if there's any precipitating factor for the symptoms that they're experiencing.
Thank you. Thank you.
So this was his MRI. As part of our 2-week rule pathway, the patient would have an MRI of their prostate. I don't know if it is easy to see, but you can see that there is an area on the left apex and there is some area on the right transition zone. So the report of the MRI has commented exactly on that. A PIRADS 3 lesion that is in the right transitional zone in the mid-gland level, and the left apex anteriorly scoring 4, which is at the very left apex, as you could see on the images just before. So the next step for us was for this patient to come in our urology department and have a local anesthetic transperineal biopsy. And the biopsy results happily have come within less than 2 weeks. And the results have shown quite significant amount of cancer. So 9 out of 24 biopsies with maximum tumor length of 12 millimeters, 1 core that was Gleason 3+3, 1 core that was 2 cores that were 3+4, and 6 cores that were 4+3. So overall, grade group 3 on ISUP or Cambridge Prognostic Group.
Do you routinely use ISUP in your practice?
I think we try to do for all the patients. I think according to NICE and according to the national guidance, we need to have the Cambridge Prognostic Group, but we try to do in order to have common language amongst all of us.
Thank you.
So the next step for us was, because of the presence of Gleason 4+3, as a protocol, the patient would have a PSMA scan. So I'm passing on
to Professor Prakash, who will explain us.
Hi everyone, nice to
PET.
see everyone. Just to make it interactive, would you humor me and raise your hand if you report PET-CT with PSMA PET? So that's about 50% of the audience, which is great, because then I can make this interactive. So this is a montage of images. This is how I look at the images. I start with the MIP first, try to localize what normal background structures are like. Some of you may be familiar with 1007, which is a tracer used in this case. Those are the parametrics at the bottom, the uptake time and the scaling that was used for these images. And then in the middle image, you've got the fused image, which is done on the fixed scale 0 to 25 hot iron. And then on the right, you've got the CT for structural correlate. So here we're looking, if you remember the histology, there was actually disease in the right and the left, so it's multifocal. And in this case, the PSMA PET scan was lighting up and showing more avidity in the left. For those of you who use the SV Maxes, you can see the left prostatic apex has got an SV Max of 10.8, and I've given you the background spleen as a reference of 15.
Professor Prakash, may I ask you why you measure background spleen SUV max?
Sure. I have to go back and say this has been quite a journey, starting off with bone scans, CTs, moving to choline, moving to gallium PSMA, and now FPSMA 1007 and DCF PSMA PYL. And just recently, last month, actually the European Association of Urology conference in London, a panel of world experts made this consensus called SPARK, which we'll come back to later. And experts currently agree that a PSMA expression score is useful for image interpretation. And this is based on the so-called literature of the PROMISE, which is now version 2, where the lesion uptake, PSMA lesion uptake, is compared to a reference organ, which is like an internal reference. And the spleen is recommended as the reference organ instead of the liver for PSMA ligands with liver-dominant excretion, such as FPSMA 1007. That is in contradistinction to DCF, PYL, and gallium, which is excreted mainly in the urine and less hepatobiliary. So they say that looking at the images with an internal reference and using SV Max is useful for image interpretation.
Thank you.
So on the basis of this, can I get a show of hands how many people are confident that this is prostate cancer? Well, you've got the histology, so you should be. But what I'm trying to show you is the level of expression in the primary tumor that can sometimes help you when you're looking for distance spread. The thinking is that when you've got METs, you can get spread, which is similar expression. We'll just go to the next slide. Thank you. This is showing you the left prostatic lobe had a much reduced, the right prostatic lobe had a much reduced PSMA expression, but it did correlate to the MRI findings, which you see in the middle column on the bottom. Next slide, please. This patient also had, as you can tell from the MIP, several lesions in the osseous anatomy. I've highlighted a lesion here in the T3 vertebral body. If you look on the MIP image, I've cross-triangulated that to the fused sagittal image. You can see there's no CT structural abnormality there. The SV max is 4.7, and again, the background spleen was 15. So how many of the audience would say that this is unequivocally bone metastasis? Okay, and so no one's putting their hand up. How many people think that it may be bone metastasis that warrants further investigation? Okay, and how many of you are saying it's just an indeterminate or equivocal finding, which is what most people are doing? Okay, next slide. So there was also a further lesion, as you can see here, in the right sixth rib. Similar characteristics where you do have some PSMA expression. It's quite low in the sense that it's less than background reference spleen. Again, on the CT, there's no CT structural correlate of any malignancy. It actually stands out better on the black and white PET images. Again, I'm just going to ask one question here. Would you all agree that this is also an equivocal finding that warrants further investigation? Yeah, everyone's nodding there. Let me show you some evidence. There's been a lot of work on this, and actually we've got some eminent people in the audience who have done some work on this as well. This was an article published relatively recently by a group who looked at skeletal PSMA 1007 uptake in prostate cancer patients, and they all agreed that there's a level of experience needed and using clinical follow-up to determine when you call something positive and negative. And the inter-observer analysis of these skeletal lesions resulted in moderate agreement in line with the rates in the literature. So this is a known problem that 1007 can cause false positive lesions and a non-malignant uptake. Next slide. Back to you, Dimitros.
Vinit, the question still remains. So the patient is suitable for all radical treatment options, and the patient has been seen by the surgical and the oncology team as per protocol. As you can see, the patient is keen for surgery. I know that might be relevant to our particular area, that some healthy, fit and affluent people, as we are judged on occasions. So it's a fit cyclist at the age of 72, and he has no previous surgical history, so he is keen on surgery. And the oncologists have discussed with him brachytherapy with hormones and external beam radiotherapy. So we are all on a limbo. What are we going to do with the findings that the PET scan has not clarified?
So there's a couple of options here. You can do serial imaging and longitudinal follow-up. How long do you wait when the patient's waiting for the surgeon who's anticipating surgery? Or do you look at the other risk factors? So this is multifocal disease. Would you classify this as high risk?
This was the reason why we had the PSMA scan, but as we discussed on the MDT, we still don't have a clear answer.
Usually, it's unusual to get rib and spine mets in isolation without mets elsewhere. It's not hard and fast, but we decided to give the patient the benefit of the doubt because of lack of a CT structural correlate. We didn't do an MRI for the spine, and we have a lot of experience of overcalling rib lesions, and we did have clinical follow-up on those patients. So using our historical data set, we were deciding to give this patient the benefit of the doubt and not overcall those bone lesions in the ribs and the spine.
But my keen surgical colleague has gone further ahead and organized the MRI spine, which has indicated no evidence of metastatic disease, which has given the assurance that we needed in order to treat the patient.
And I think that's a good learning point, that when there's spinal uptake, I think you should correlate with MRI spine, and that was a good learning curve. And the more you do that, the more confidence you get for the MDT.
Dr. Mosconas, may I ask you, initial staging of high-risk prostate cancer patients, the first modality that you used was PSMA PET. Why we did not use conventional imaging modalities, for example?
I have to answer on the basis of what is our common practice that we established in our center with the help of Professor Prakash and the team pushing for that we are getting lower and lower number of conventional scanning, and the patients with at least one high-risk feature, meaning either preponderance of Gleason 4 or T3A disease or PSA above 20, these patients will have a PSMA scan.
Yeah, I think we've done a lot of work talking to the commissioners locally as well. So yeah.
It's been a journey. I don't say that it happened in one day, and all of it is a lot of effort from Professor Prakash and the team to convince people around, but this is our practice now.
I think it's a local practice, yeah.
Thank you. Thank you very much. So this was the first
This
case
was the
report
first case.
about staging of prostate cancer patients. Let's go to biochemical recurrence.
So our MDTs are having a lot of patients with recurrences of disease, so because these are the most interesting patients to discuss as well in more detail. So this patient was a 62 years old, initial presentation of prostate cancer in 2024. Sorry, I forgot to mention that we are a cancer network, so we get referrals from the neighboring hospitals as well, and I will explain why this is not a case of ours and this was a case from a neighboring hospital. So PSA of a patient was 6.9, then the GP has done their due diligence and repeated the PSA in 2 weeks' time and have seen that the PSA has gone slightly up. His past medical history includes sarcoidosis, osteopenia, and appendicectomy, and he's currently on prednisolone because of the sarcoidosis. He has minimal symptoms, he has normal erectile function, and GP was very good in performing a DRE, which has shown an enlarged prostate but smooth otherwise. So the most important part at this stage was that taking the history from the patient, we realized that he has a brother that was diagnosed with prostate cancer. He's now aged 71, and he was treated with chemotherapy and radiotherapy because he was found at an advanced stage.
How important is a family history in patients with prostate cancer?
I think it is quite important because we take that part of the history. It seems like patients with a first-degree relative that was diagnosed with prostate cancer at an early stage in life have at least 25% chances more of developing cancer themselves. So we tend to look at these patients in more detail. This was his MRI, which was showing some PIRADS 3 changes in the peripheral zone at most, and then the biopsies have indicated under local anesthetic Gleason 3+3 or ISAP1 in 1 out of 21 cores. So the maximum tumor length was 0.6 millimeters. So for the rest of the audience, this is a classical case for a patient to go on active surveillance. Obviously, we have discussed all options with the patient, but he opted at this stage in life, at the age of 62, to closely monitor his disease. The next step was a year later, where the patient had his follow-up scan in April 25, and this has indicated a bit more prominence of the lesion within the right anterior part of the prostate. And that hospital, because I'm telling because it's not our common standard practice, at this stage we're doing repeat GA biopsies for all the patients on active surveillance in 1 year, regardless of what the features of disease are. So the patient was reporting well in himself, and the pre-op assessment has indicated that the patient had an infection. So this delayed the further biopsies.
But 42 biopsies, is this a routine practice in your hospital, 42?
I have to confess it's not, and we have discussed with this hospital that is a bit of an outlier. So their protocol was to do saturation biopsies on the first set of biopsies after the original diagnosis, but we have understood, all of us together, that this is not the right thing, especially on a prostate volume, as you can imagine, that is less than 50 cc's. So it's too much. So 4 out of the 42 have indicated Gleason 4+3 with maximum core length of 6.9 millimeters and with some extraprostatic extension. Obviously, the histology report of extraprostatic extension is not always a significant factor. It has to be taken with a pinch of salt, but we still take it into account. So the next step was the patient decided for robotic radical prostatectomy, which happened in September 25. This is the usual toy that we play weekly. So this is giving the patients quite good outcomes for their operations. So the final histopathology. So this has indicated that the prostate volume was 40 cc's. Tumor was involving 5% of that 40 cc's. Primary score 4, secondary 3. But as you can see, there was extraprostatic extension, so that correlates with the biopsies that we had before. And the margin status seems to be involved. So we have pathologists that are very meticulous in measuring the positive margins, and they have shown that the combined positive margin was 8.3 millimeters. So the conclusion 4+3 with focal extraprostatic extension and margin involvement. The next step for this patient, he's gone home day 1 after the operation. He was recovering well. A second appointment, the first appointment was just to discuss his functional outcomes, and the second appointment he discusses that he doesn't have any lower urinary tract symptoms anymore, so he has very good control of his urine function. And as expected at this early stage, he has some erectile dysfunction, so his sildenafil dose that was started on the first appointment was now increased. But as you can see, the red flag for that was that his first postoperative PSA was 0.678.
And when do you usually perform the first postoperative PSA, and how often do you perform this?
We do that at least 10 weeks after the operation. So the idea is to give enough time to wash out completely from the bloodstream. And then for the patients with some of the high-risk features that we have seen here, we tend to do it 3 monthly for the first year, 6 monthly the second and the third year, and yearly afterwards.
Thank you.
Sorry for that. So this was obviously the red flag. So the red flag meant for us, as per protocol, that this patient should have a PSMA scan to understand if there's any significant disease. So I will possibly pass on to Professor Prakash, and we'll go back to that.
So same sequence of montage of images. You've got the MIP, the tracer again is 18F PSMA 1007. The parametrics and uptake times are as written on the slide there. On first impression, there's not much to see here with 1007. You can see normal excretion in the liver and in the gallbladder. And once again, we would use the spleen as a reference organ for that reason. Looking at the prostate, on closer inspection, there is a focus anteriorly, which is PSMA avid, towards the apex. It's got an SV max of 3.3. Compare that to the background spleen of 8.5, so that would be considered low. On the CT, there isn't really any structural correlate. Next slide, please. And if you look at the MR, however, there's a good concordance of an abnormal low signal abnormality in the MR correlating to the area of increased uptake on the PET. And this double match would be in keeping with recurrence. Next slide, please. Again, if you look closely, there is actually uptake again in the rib. In this case, it was the right lateral third rib. The SV max was 4 compared to background spleen of 8. If you recall, the recurrence was a similar low PSMA expression, so what do we do here? So show of hands, how many people will be confident to say this is a definite metastasis? And no one's put their hand up. That's purposefully asking that way. How many people would say this is an equivocal lesion that warrants further investigation? No one put their hand up. And how many people would be happy to say this is a negative for bone metastasis? Okay, so that's what the majority of people are saying here. Next slide, please. So just some more evidence-based background. There is a difference in tracers, as I alluded to with case 1, between the different PET tracers. This was a study that was published which looked at a head-to-head comparison using a matched pair comparison of 18F DCF PYL versus 18F PSMA 1007. And what they found was, if you take the whole of the osseous skeleton, you see a larger number of non-malignant findings or cubical lesions with FPSMA 1007. You can see at the bottom right, that's quite a significantly larger number. 30% of equivocal lesions were seen with FPSMA in contradistinction to 7% of equivocal lesions with DCF-PYL. I think it's important to know the differences when you're reporting, that might change your threshold for overcalling or undercalling something, which makes a big difference to the management of such patients. So I'm pleased to say that most of the audience members agreed with what we said, and we said this is unlikely to be metastasis. Back to you, Dimitris.
So, as you can see possibly from the slide, so this case was first discussed in the absence of Professor Prakash and myself because we were on leave as it was Christmas time. And at this time, we thought that the PSMA report was not conclusive, so we needed further discussion in order to understand what the next step should be. So the second time that the patient was discussed, the idea from discussing with nuclear radiologist and the diagnostic radiologist was to offer the patient the MRI that Professor Prakash has already shown. This has shown suspicion for local recurrence, and this was the one that was confirmed by the MRI. And we have to say that this is not a standard practice, but at least when we have the suspicion, we'll order an MRI for even patients with recurrence, because that might allow us to target treatment accordingly.
Yes, and this is a case where you have histological confirmation of PT3A, which is extracapsular spread, so this patient would be a high risk of METs, and that's why it's important to put everything together when you're at the MDT.
And so the outcome from the MDT was that the patient should have prostate-paid radiotherapy, so he was referred to oncologist, started on hormones, and he had his treatment started a couple of months later.
I should say that our MDT, I don't know if you do have your MDTs, we actually have a dedicated radiologist who just reports MR prostates, and then you've got myself, so we've got two imaging experts. Although I'm a radiologist, I don't routinely report MR, so it's quite nice to have a second opinion from the radiologist to correlate the functional PSMA with the structural MRI.
Thank you. Let's continue our MDT meeting.
Excellent.
So the third case, also biochemical recurrence.
So this is another 63-year-old gentleman that presented with a PSA of 4.6, and on repeat this was 6.9. So this was the point that the patient was referred to us in 2023. He doesn't describe any change in his lower urinary tract function. He describes some nocturia, however, and mostly symptoms of frequency and urgency with a score of 20. Just to remind, the score goes up to 35. And that means that the patient with a score above 20 seems to have a significant burden in their lives. So 2 pints of coffee again, Marina. And so his urodynamic features have shown that he's having some obstruction, so the Qmax is indicating the flow of his urine. That should be anything above 15, it's 10.9. So patient originally discussed with the doctor all the options, having an MRI and possibly having a biopsy, but decided to go on monitoring of his PSA because of the discrepancy between the first two PSAs. Patient was advised to wean off coffee, and he was happy with the symptoms as they were at this stage. Following up, PSA 6 weeks afterwards has come back as 5.8, so it was considered therefore that it was a real reading that was high, so a multiparametric MRI was arranged. Sorry, I'm jumping and giving you the PSA density on the basis of the volume of the prostate, but this has then indicated these areas that you can see on the MRI, and the patient underwent in November 2023 biopsies of his prostate that have indicated Gleason score 3+4 in 11 out of 21 cores with maximum core length of 14 millimeters, so ISUP grade 2. It was considered to be organ confined, therefore all radical treatment options were discussed with the patient.
May I ask you, patient declined biopsy. What do you think about role of PSMA PET in such a situation?
I think it's an interesting conversation. We struggle to convince people to have it done after original diagnosis, so I think we will have some difficulty convincing them to have it as a primary staging. But there was an interesting article that Vinit was sharing with me yesterday, so...
Yeah, I mean, again, last month at the European Association of Urology, there was lots of good data presented, and the Peter Mac Centre in Australia, their team presented a paper based on their Primary 2 trial. I don't know if you've heard of the Primary 2 trial, but This was a phase 3 study which looked at the use of PSMA PET-CT in men with clinical risk factors but non-suspicious or equivocal MRI findings. And when they did their study, the results showed that PSMA PET reduced the need for prostate biopsy by nearly half in such patients without significantly compromising the detection of clinically significant prostate cancer. So there are people working in this space, but I guess for now, we don't have sufficient evidence, and watch that space.
So we continue with MRI after.
I think so. So the patient had appointments with all teams to discuss options. He was really worried about potential side effects of surgery. External radiotherapy was discussed in detail, but he found the time commitment restrictive for his active lifestyle. So he found more attractive to him brachytherapy. So as you might know, we are a world-renowned center for brachytherapy as well, so it was quite attractive for the patient. So sorry for the picture showing how the brachytherapy is done, but for those who don't know, seeds emitting radiation are injected in the prostate under general anesthetic or regional anesthetic, and the procedure is lasting 45 minutes, so it's one off, and that is quite attractive to the patient because it seems like it is not as invasive as surgery. Even though, if the discussion goes on, I can explain to the patient that surgery is not that invasive nowadays, so I could show them our results. So the brachytherapy follow-up. So the PSA has nadired at 2.5. You remember it was up to 5.8 on presentation. This has happened 18 months after the radiotherapy. There is a red flag there that says that the nadir only reached 2.5, so we would expect possibly the PSA to go further down, but we keep that in mind as we keep an eye on the patient for the years to come. At the time of their follow-ups, the patient will have the male health questionnaire that will give information on the IPSS score that we touched upon before, the quality of life, the erectile function score, and the bowel score. So it seems like, again, there is a bit of a red flag there with regards to symptoms from their bowels. So what happened with him was that in December 25, the patient came in with an episode of hematuria. We would investigate the same way as we would investigate for any other patient, obviously knowing that there is a risk factor of the brachytherapy/radiotherapy causing the hematuria, but we need to rule out any other particular cause. So he had a CT urogram that has shown no cause for his hematuria, but indicated a tiny focus on the transverse process of L3 concerning. And then the radiologists have done their due diligence to check on the electronic patient record, and they have reported that in light of PSA rising and nadir only reaching 2.5, this should be further investigated. So this patient has come to the MDT for discussion. The discussion has implied that the patient should have a PSMA scan to understand if there's any recurrence.
Thank you. So that was a good pickup by the radiologist using all the information available. I don't know how many of the radiologists in the room have access to EPR routinely when they're reporting or indeed use it. But they spotted the rising PSA. They actually looked at the image and saw that as a lesion, sclerotic lesion in the L3 vertebral transverse process. So this is the PSMA PET, which was used to further examine and evaluate that L3. Again, same montage sequence. You got your MIP, again, with 18F PSMA 1007, same parametrics. And in this case, we looked at the prostate first, which showed very low PSMA expression in the prostate. And then we move on to look at the left transverse process of L3, which was the reason for doing the scan. And there is a sclerotic focus, but this is not PSMA avid. Show of hands, how many people are very confident that this is negative for bone metastasis on the basis of this? Okay, no one's putting the hand up. Would you, show of hands, how many people would suggest we go on to an MRI? Okay, no one's putting a hand up. So what we did, we actually looked at the whole of the scan, because one swallow doesn't make the summer, so we're looking for number of lesions. There was actually another lesion which was sclerotic in the left sacrum. Here you can see that PSMA avidity is SV max 4.7 compared to background spleen of 8.0. So this lesion is a bit more worrisome than the one we saw in the transverse process. And furthermore, there's an additional finding in the osseous anatomy, in this case, yet again, in the right lateral third rib. I don't know what it is with third ribs in particular. PSMA was 4 and the background spleen was 8, so low PSMA expression. On the CT correlation, once again, there's no CT correlate of any malignancy. So just to help you, this is a further homunculus taken with 1007 data by Gröning et al. And they found that when you divide the osseous anatomy into different sections, the ribs and the pelvis are some of the most common areas for these non-malignant PSMA uptake. So in the ribs, for example, you have more than 50% of lesions can be present, which are non-malignant, and you can see the different areas of the body. So in this case, we had a lesion in the right third rib, we had the lower lumbar spine in L3, and we also had the bony pelvis.
Vinit, we're still on the limbo. What are we going to do with this patient?
So we were very confident to say that the L3 lesion is probably not a metastasis. We were concerned about the sacral lesion, and the rib lesion we were discounting on the basis of the previous 2 cases in our history of that rib lesions are often overcalled with this tracer. So, and this slide, I think, summarizes that well, that the L3 transverse process is not avid, so it's not a metastasis, and we use that as a rule out. The faint uptake in the prostate, could it be some residual old cancer? And this sometimes can be seen, but this patient's 20 months post-radiotherapy. There's a faint uptake in left sacral area, which I thought was faintly visible on CT, and there's also faint uptake in the right rib. So I think it's really important to understand that how we interpret at the MDT makes a massive difference to management of these patients, and the knowledge of the tracer and their distribution and causing false positives is very important. Back to you, Dimitrios.
I think the management of this patient is not easy. So essentially, you need to hold your nerve, because with this patient, essentially, the decision-making was led from the discussion. So the fact that it was only faint uptake within the prostate meant that we should possibly hold fire about repeating biopsies. So in these patients, if there was something that was largely avid in the prostate, then we would possibly do an MRI of their prostate to guide some biopsy taking from that and see if there's any obvious recurrence. And that's how we decided that no prostate biopsy at this stage, but keep a closer eye compared to the other patients. So it's difficult sort of discussion and conversation with the patient, and it's equally difficult conversation with the oncologist in the room when we have these discussions, because they want, and we want, arbitrary answers, but we don't have them.
I think it's important as reporters sometimes hold your nerve, and sometimes we're held with a gun to our head and say, make a binary positive, negative, and it can be quite challenging. So this case illustrates the value sometimes of holding your nerve.
And before we go to the conclusion and to answer the questions, are really all fluoride-labeled PSMA radiopharmaceuticals the same? I would kindly ask you to scan this QR code and to answer just 3 questions. They are not clinical questions. They are questions about PSMA availability, PSMA radiopharmaceutical availability in the United Kingdom. In the meantime, what have we learned today?
So if I can kick off first, I hope that some of you know this already, and those of you who don't, this is another homunculus showing you the different tracers. This is just but 3 of them. So on the left, you have your 18F PSMA 1007, which all 3 cases had today. You've also got gallium PSMA and 18F DCF PYL. What you're looking at here is the distribution, or the incidence, I should say, of bone uptake on scans using the 3 different tracers. So they all show quite, and red is high incidence, and the other colors, as you can see from the schematic, is low incidence. You can see that they all have high uptake in the ribs on this homunculus, but in the bony pelvis, it seems to be from the literature that we have got so far that 1007 has got a high incidence in the bony pelvis compared to gallium PSMA and DCF-PYL. Also, whilst I've got this slide up there, important to know the difference in the routes of excretion of the tracer. So as I said, PSMA 1007 is mainly by the hepatobiliary route, so don't use the liver as your reference. And actually, that's got an advantage for looking for recurrence near the surgical anastomosis in the pelvis, because you see less urine uptake with this tracer, so pluses and minuses of 1007. The other 2 tracers are mainly excreting the urine, so you can use the liver as your reference organ. The other thing I hope you've picked up is, and this is a nice example, of the same patient having both 18F PSMA 1007 and 18F DCF-PYL PET-CT, which was done as part of a research trial. So that's how they got away with using 2 tracers. And this is...
Yes, this is a Spark article.
Yes.
Published. You know that authors, there are approximately 30 authors of this Spark initiative article. And what is interesting, they agreed that PSMA expression in the bone without anatomical correlate should be interpreted as bone metastasis. Professor Prakash, do you agree with this statement?
This only came out last month, so I'm just processing it at the moment. And so again, just to go back, Spark is a global consensus of experts, and they did a Delphi consensus over 2 rounds with 93% agreement in the statement. And it's quite a strong statement, isn't it, that PSMA expression in the bone without anatomical correlate should be interpreted as bone mets. And this is the expert panel saying this. Now, if you take this patient and you only had access to 1007, you'd call these 3 lesions as bone mets. And that would change this patient's management from potentially radical options to oligometastatic disease. And the same patient, if you're using DCF-POL, has got no bone uptake, irrespective of whether they've got CT correlates, and that would be considered negative for bone mets. And that patient would be considered for all options, potentially. So I think one takeaway is be aware that it's an ever-evolving field. Be aware that these are guidance statements, and be aware that the difference in traces can make a profound impact on your patient.
Thank you, Professor Prakash. Dr. Muskonas, what we have learned today?
What we have learned by working with you is that we need you. So I think a nuclear radiologist is an important, vital part of the MDT, because we need to understand the significance of the findings that we have in the scans. What we have learned with the process is also, and that we have convinced our nuclear radiologists to put it on the reports, is to understand which of the agents they have used in the scan. So this was not part of the reporting before, and we have managed to convince Vineet and his colleagues to do that, because that is also helping us interpret the results, obviously with their presence in the room and not without them.
So, my dear speakers, I think we have no time for questions, so we will go to thank you slides. Firstly, I would like very much to thank you both for this journey. Thank you for making this MDT for us. Then I would like to thank my great colleagues, great Curium UK team for organizing this symposium. Thank you very much. And most of all, thank you all for waking up so early and showing interest in innovative radiopharmaceutical for prostate cancer. See you, looking forward to seeing you next year. Thank you very much.